So, for the first session, for this session, the first lecture is on dyslipidemia, and we all know Dr. Uday Jadhav. He has frequently traveled to Rajkot and delivered so many talks in previous our conferences. Sir is honorary faculty and professor at Cardiology and Cardiac CT and MRI Department, MGM University and Health Science, Navi Mumbai. He is Vice President in Heart Failure Association of India, CSI Mumbai chapter, and Indian Society of Electrocardiology. Sir has presented numerous publications and he has won many awards. Over to you, sir.
So thank you very much for this opportunity. It's been really a pleasure. Thank you, my friends, Dr. Girish, Dr. Joshi, and the entire physicians group from Rajkot and Saurashtra. It's a pleasure listening to Professor Dr. M.B. Agarwal. Such a learning every time. I wish we had more teachers like him and better students also to grasp everything that he gives. I dedicate this lecture to Dr. Samuel Matthews, who passed away yesterday, a doyen of cardiology, who has probably touched many lives and a phenomenal interventional cardiologist who could fix everything. Having said that, that brings us to the whole subject of lipids. What we have been doing, what do we have as on now? And I'll start with 4 or 5 very important and crucial slides to put the tone in. See, we are aware of it. Why do we show these slides again and again is because why do we need to at all reverse atherosclerosis if possible, and where is the whole gambit of whatever we are trying to achieve? You know, I think we are much younger population. Our atherosclerosis is so very different. A part of it is now already known, very well known. A part of it is not well known. Young patients coming with diffuse, and that's the point, that's the whole crux of this lecture, coming with diffuse atherosclerosis, identified and fixed by a particular type of revascularization. But what happens to elsewhere? How do you address the whole atherosclerosis in the coronary arteries, because that's responsible for a large number of events that we are seeing. The very well-known fact is you give a high dose of statins, right? I'm not going to touch on statins too much today. It's a very well-known knowledge, so let's not get into a dull phase. The point is this, that as you jump your statin dose and go up, you actually at, let's say, 80 milligram dose of atorva or 40 milligrams dose of statin, get down all that composition of death, MI, and stroke by close to about 25%. And it is quite safe. So it shows you what happens when you jump these doses and what you get with the highest dose. The adverse events increase marginally, leading to discontinuation. That's true, we cannot rub it away. The liver enzymes stay put, and the neurocognitive effects actually don't differ. My point of contention is, between the mid and the highest dose, there is not much of a difference in what you will achieve in terms of benefit and what harm it will cause to the patient. So I see a lot of patients post-PCI who continue to be on 20 atorvastatin or 40 atorvastatin or 20 rosuvastatin for whatever reason a clinician thinks that's appropriate. It's not appropriate because you are hanging on to this figure only. You need to get it down to this. Get the point? This is a very well-established literature and a very well-established science. The other thing, and this comes from the recent therapies which are available. You know, when you start a dose of lipid-lowering therapy, whatever that is, hydrostatin, inclisiran, evolocumab, and you drop the LDL-C level, and for some reason you reduce the dose or stop the dose, the LDL-C goes up. It is this variability. This is called as LDL-C variability. Look what happens there. The coronary events, any events, deaths go up very high. So the moral is LDL variability matters. The moment you drop the doses, reduce it to half, drop it, you will have more and more LDL variability. So it's becoming like, let's say, if you have a patient with 170 by 100 blood pressure and you're not very aggressive about the therapy, you can slowly go up, 180, 90, 200 by 100, but it's not catastrophic, right? By and large. But then, in between you have those set of patients where the blood pressure can become 220 by 120 and he comes up with shortness of breath and a HFpEF. One acute event suddenly triggered. The same is true with LDL variability. That when LDL variability is there and the LDL suddenly jumps up, in a given week, you may probably get a plaque rupture. And that's why the new therapies are going to be extremely important in terms of what we are going to do. So last year I was doing these lipid meetings across the metros in India, and with Dr. Kaushik Ray, and who does all this work on the newer molecules. And the question he asked is that, because that's what we propose, that in India, when post-angioplasty you put the patients on a high dose of statins, they do very well, and we don't really require a high dose of statins. We achieve the LDL. Now you know all the guidelines. What does the guideline tell you? If you have a post-PCI patient, you will want their LDL to be in the range less than 35 or 30. Always less than 45. There is no guidelines that tells you you should not have it less than 45. So it's in a thought that is going to work. But when I looked at the entire data, you know, it is shocking. We have just 2 papers from this country. Just 2 papers. This is Ajit Mulasari's paper from Madras Medical Mission. That post-ACS patients who are on statins, look at the LDL targets. Less than 70 in 45, less than 55, barely 20% of the patients. Now you know why patients get revascularized again and again. They come back for another stent and the third stent, and the PCIs go for CABGs, and the medical patient go on getting angina on a high dose of statin. This message is very big. This is the only clinical trial I know of that is substantial. Nothing else in this big country comes out from all who work and research in lipids, including myself. So, moral of the story. We should not have thought processes which are not justified. We should have evidence, and this is the evidence. All right. So what do we have today? Look, here are the biological issues in lipids. Here are the markers in lipids. So do we have a marker for lipids and residual inflammatory risk? Yes. What we don't have, and we need to remember this very clearly, and this is a new era of lipid therapy now. The thrombotic risk has no marker. There is not a single test that will tell you. A patient will come on one fine day, 4 a.m. in the morning, with a thrombus in the coronary arteries. We don't know. There isn't a marker for that. Triglycerides is, I'm sorry to say this, but I'm completely surprised why we still sit on fenofibrate. I was involved, in fact, for getting pemafibrate for a clinical trial in India from Japan, which is the largest trial after IMPROVE-IT with ezetimibe. The trial was negative, presented at ACC, and then the editorial saying, this is the lid on the coffin of the entire triglyceride therapy. You are not supposed to take care of triglyceride. You are supposed to take care of the non-HDLC. Take care of the non-LDLC and take care of the residual risk. That doesn't necessarily come from triglyceride. To the extent it's a big molecule. We don't even have a proof that the triglycerides will go and get from the coronary circulation imbibed in the wall of the vessel and cause atherosclerosis. It's too big a molecule. And therefore, triglycerides have never been individually proved to have a direct correlation with atherosclerotic CAD. Every single trial has failed. You can, of course, use omega-3 fatty acid for looking at the entire ApoB, but otherwise, no. All right. So we have now inclisiran. I do not know how much we have been using it. Let me share with you. My experience has been modest. I have patients who have completed all the doses, and we have been able to achieve LDLC is around 20s, one patient of 10, but that's about it. It's pretty interesting, but this therapy is here to stay. There are two slides I'm going to show you. Why should you pay attention to it? If you don't pay attention, then you won't be able to comprehend any lipid therapy that is going to come in the future from now. This is the structure of inclisiran. So inclisiran is a small interfering double-stranded messenger RNA, right? It's an interfering therapy which has two strands. One is called as the sense and other is called as the antisense. It is the antisense which is very important. That's the interfere. That's the interfere in the entire cholesterol metabolism. And this whole conjugate, as you will see in the next slide, is brought about by GalNAc. GalNAc is one of those specific enzymes that will sit on the liver cells. I'll explain it to you in a moment. That makes inclisiran, unlike statins, unlike your other therapies, free of side effects. It has no off-target effects, right? So let's show you that and pay attention and I'll explain it to you. Here is that. So if you remember the space shuttle program recently where Sunita Williams was brought down, a couple of days before there was a space shuttle which went up from NASA. Exactly that's how inclisiran works. Here is your inclisiran. Here is your GalNAc. So what GalNAc does is, it gets it to a receptor called as the asialoglycoprotein. Let's call it as the ASG. ASG is the receptor. You see this umbrella on the liver cell. This is the liver cell surface. It sits here. The GalNAc, this yellow stuff, this is like a spacecraft getting on the surface of the moon. This is the head of that spacecraft and it sticks to the surface of the moon here. That's the hepatocyte SGPR. Once it gets inside the cell cytoplasm, this particular stuff, the GalNAc, will get destroyed. Because the GalNAc gets destroyed, there is no other side effect of inclisiran that can possibly occur because there is nothing left outside the liver cell. No systemic side effect. Once that happens, what are we left with? We are still left with this umbrella here, right? And we are left with this inclisiran. The inclisiran stays here. The inclisiran stays here. This particular thing is recycled back to the cell membrane. So these receptors on the moon surface continue to remain to attract more inclisiran molecules whenever you require to administer them 3 months or 6 months down the line. So what are you left with? Just this strand, right? So this inclisiran strand as it gets released into the liver has two parts. It's called as antisense and it's called sense. Sense is gone, it gets degraded. That leaves you only antisense. This is active inclisiran. It gets attached to the PCSK9 molecule here. So here you have a whole complex now. You have the PCSK, you have the inclisiran antisense. This particular thing then will lead to a reduced production of PCSK9. That's how PCSK9 gets inhibited, unlike your other PCSK9 inhibitors that directly acts. But what's important here? It gives back more LDL receptors because the PCSK9 is gone. If you have more LDLC receptors, your statins work. See? So, statins help PCSK9, PCSK9 helps statins. This is a very complementary thing that goes on in the available therapy. That's the basic. And now there are three things where it's indicated. The indication which I feel is going to be extremely important besides the three offered ones. These are the three offered ones in clinical practice and which I have used are patients where you have 80-90% lesion is fixed, is on high dose statins, LDLC is 50, let's say 50. But he has lesions in circumflex and RN and other places and they are like 30-40%. How will you take care of them? They won't regress at 50, mind you. They are going to increase or they are going to create a plaque rupture. That's the point of time where inclisiran in multivessel disease can help. 3 doses, as you all know. First dose, second dose at 3 months, then every 6 months, and then twice a year. Now, can you give it at 3 months or 4 months? We have looked at it carefully in literature and otherwise also, that it does work at 4 months also, but you might get a little higher LDLC. So sometimes in Indian patient, this is just an Indian experience, by the way, we do find that at 4th month also it works, right? But the 3 doses stick and it gives you an extremely good response. Subcutaneous on the abdomen, absolutely no side effects. I haven't seen one, not in a single patient. No drug administration, no carcinogenicity, no off-target effects. Very, very good, right? So I think that works. There are trials which have shown that it is very successful. What does it do? It drops down the LDLC by 50%. That's the main thing. Now, can you wait or not wait? That's the trial called Victorian Initiate, which was shown last year. So what they did is, for patients on high-dose statin, they gave inclisiran straight away, not wait for 3 months, 6 months, and then here are the results. You see the difference? This is for patients where there was a wait and inclisiran was given later. These are for patients initiated early. Excellent response, 60% drop, very good. So there is a tendency now in acute cardiology practice to start inclisiran early, and there are new drugs which will come off, which we will talk about. The second part of my 5-6 minutes or whatever is left is what is going to be the present and the future. That's the lipo-A, the lipoprotein small a. I'll talk about it. So now, there are only 3 targets. LDLC is the risk. The residual risk will come from 2. One is the oxidized phospholipids, which are on the surface of the ApoB, all right, besides LDLC. And the third is the molecule of lipo-A, which is genetic. What is the cutoff? It will vary according to the ethnicity. A level of 30 in Asian Indians is believed to be okay. 50 is acceptable. Above 50 is high. Now what's this whole ball game? Lipo-A determines your entire risk. It's nothing to do with your diet or exercise or your LDL levels. It's linked to your familial pattern and your genes and your premature coronary artery disease in your parents, and you can do nothing about it. So if you have the lipo-A, you know what is that genetic marker that will help in reducing the risk. Between different ethnicities it's different. This is the Southeast Asians. So the Southeast Asians have a little different curve than the rest of the world. Cutoff should be at about 50. What do the current guidelines say? And that's important. That's all, everything put together. Now, if you look at it, once in a lifetime for sure. So if you go to the ACC US meeting, they have a booth there where they do it for free. I got mine and it was $5. I was reasonably happy. So once in a lifetime, you must do it. All of you must do it, wherever you are. You will not know otherwise what is your genetic risk. Simple, straightforward. All individuals with a premature family artery disease, that's very important in Indians. Parents having premature CAT, mother, father, less than, Indians could be less than 50s or 60s. Make sure that you do it. Those with a high ASCVD risk, those who have already taken a high dose of statin but it's not working, you necessarily have to do it. The risk can be lowered when you get down to less than 30. Now, how much it should be? Whether there is a baseline, that's good. Like if you, let's say your level is 100, if you get it down to 30, will that be good? Or let's say your level are 150 and you touch 90, will that be good? That's something which we don't know as of now. The belief is, if you get your quantum of LDLs, of lipoprotein A between down from the baseline by 60 to 80 milligrams, your risk is then eliminated. That's important to understand as one theorem. There are plenty of drugs which are studied now, right? So if you have been looking at all last 3 years conference in United States and in Europe and this year's ACC, it's all about this, right? There are plenty of drugs because look at the lifetime risk. This is LP of 7, this is LP of 150, lifetime risk. This is very recent data. in European Heart Journal. It's so high, and why is it so high? If you take a molecule of LDLC and a molecule of liposmall a, the atherogenicity given, offered by a lipo A is 8 times more than the LDLC. So your 8 potential fold increase in the risk and increases your genetic part. The atherogenicity is more than 6-fold higher when you look at clinical risk, so that's also very high. So there have been 3-4 studies which came up this year, and you should know about these studies because they are the future now. One of the trial is an oral drug, and that's very interesting because inclisiran is injectable. So you can start looking at oral drugs, and they have been also at a 30 milligram dose able to reduce the LDLC by 50. So the Pursuit study was presented last month in ASSC, and it's a once daily oral inhibitor molecule. The other drug, which is made by the makers of inclisiran, is pelacarsen by Novartis. And the lipo-A goes down between 35 to 80%. Lowering of LDLC is only 20%. So this is a molecule specifically going to be marketed to lower your LP little a. And I think this is extremely promising. This molecule is by Amgen is extremely promising. All the data are out. It's called as the OCEAN study data. Olpasiran will lower the LPA by 70 to 90%. I think this is very relevant in India. Amongst the youngsters in the family who have CAD between 35 and 60 years, this could be extremely important drug. Because you give statins or inclisiran is needed, and you lower the LPA when it's elevated and eliminate it. Your premature CAD and the family history of atherosclerosis is well taken care of. You have Solbinsiran is just like inclisiran, a little less modest in my opinion, and we are awaiting the trials. And finally, let me come to this. So why do you measure it? It's causal. It's common, it contributes to risk, you can act now. And a nice quote that it's difficult to explain to patients about high LPA test result. If you don't test it, you don't need to explain. So you need to get on with it. You cannot wait anymore, and let's start doing it more often. Just to finish my talk, just a food for thought. So we do a lot of cardiac CTs and now cardiac MRs also. So while working with the department, I said, what do we have? So everyone undergoes calcium score in my hospital. I'm saying all doctors, all nurses, all paramedical, there are 1,200 people who undergo that. I'll finish it at that. So what did we say? That when somebody's LDL is high, we say, let's look at his calcium score, right? Those are the guidelines, and take a call as a referee. So I said, let's look at our doctors and our medical people. Let's select those people whose coronary calcium score is 0. And they don't have premature CAD, they don't have diabetes in family, they're non-smokers. And we analyze only those patients and said, what can probably be their LDLC? And presented that abstract at Washington last year. And we saw that when their LDLC exceeded 118, there was certain calcium. All who had 0 calcium had a LDLC less than 150. This is very interesting, and that made us think that here is at least a marker. No lab should write a range of 130 LDL as normal, not accepted. That's murdering people. Every one must have their LDLC less than 100. Why? Because this is a small sample study. When you look at general population, labs must get it down. You must have it less than 100, and then we have to be aggressive about lipid therapy. Is that the last slide? Has to be. So, we are talking about inclisiran, give that, expensive medicines. That's not life. What is? Is lifestyle still important? Extremely important. Look at it. So on top of getting your LPA down, if you get your exercises and diet in order, you are good. That's the bottom line of everything. Thank you very much for the patient hearing and the little time.
Thank you, sir.